as co-moderator, who needs no introduction. So we are just going to remind everyone that we have 4 presenters. There will be 8 minutes for a presentation and 4 minutes for discussing. For the discussants, please identify yourself by name, institution, and whether or not you have any conflicts of interest. So our first presenter is Florence Behane, and she's going to be talking about the impact of parathyroidectomy on insulin resistance in patients with primary hyperparathyroidism.
Okay. Good morning. I'm Dr. Florence Behane, a general surgeon from Nancy, France, and I would like to thank the AAES for allowing me to present our work on the impact of surgery on insulin resistance in patients with primary hyperparathyroidism. We have no disclosures. Pathogenesis of glucose abnormality starts with an increase of insulin resistance. This increase of insulin resistance will lead to an initial compensatory hyperinsulinemia. Indeed, to compensate this increase of insulin resistance, pancreatic beta cells will have to overwork and produce and secrete more insulin. And this overwork from these pancreatic beta cells will lead to their dysfunction in time. And this will have as a consequence a decrease of insulin secretion. And the association of high insulin resistance and low insulin secretion will lead to fasting hyperglycemia. Since the 70s, glucose abnormalities have been studied in HPT patients. It has been shown that insulin resistance and prediabetes are 3 times more frequent and severe in HPT patients compared to the general population. Studies have also shown that prediabetes and insulin resistance are associated with cardiovascular events, metabolic syndrome, and progression type 2 diabetes. Indeed, the European group of study of insulin resistance have validated that for non-diabetic patients with insulin resistance, there was an increased risk of coronary events. So what is the impact of surgery on insulin resistance? Well, it's controversial. Indeed, only some studies have shown that surgery could improve insulin resistance in HPT patients. And given this conflicting data, there are no current guidelines recommending surgery to control insulin resistance in HPT patients. However, no studies have evaluated if existed predictive criteria of improvement of insulin resistance after surgery. This is why the aim of our study was to evaluate the evolution of insulin resistance at 12 months after surgery, according to preoperative severity of glucose metabolism. We include all consecutive HPT patients who underwent surgery in our center from January 2016 to July 2021. We excluded 301 patients, mainly for missing data. We also excluded diabetic patients to minimize biases. All included patients had a preoperative workup and a post-operative workup at 12 months. Patients were classified for their surgical indication according to the 5th International Workshop Guidelines. To define glucose metabolism, we used the homeostasis model assessment. For insulin resistance, we used HOMA-ER, and for insulin secretion, we used HOMA-B. Insulin resistance was defined as HOMA-ER superior to 2.5, and we also used the European definition. For prediabetes, we mainly used the American Diabetes Association definition. We also used the WHO definition for one comparison. The WHO definition is the most used in Europe. Our primary outcome was HOMA-ER changes after surgery. It was defined as HOMA-ER at 12 months minus HOMA-ER pre-op. So our results. In total, we included 231 patients. Mean age was of 63 years old, mean BMI 26.6, and most of our patients were female. Mean calcium was of 109.9. 87% of our patients had at least one criteria for surgery according to the guidelines. When analyzing post-operative changes of glucose metabolism after surgery in all patients, we did not find a significant decrease of insulin resistance, significant decrease. However, when analyzing HOMA-ER changes after surgery according to preoperative glucose metabolism characteristic in the urinary t-test, there was a significant decrease of insulin resistance for patients who were insulin resistant, according to the European definition and HOMA-ER superior to 2.5, for patients who had a beta secretion superior to 75%, and for pre-diabetic patients. We did find a significant negative correlation between HOMA-ER changes and preoperative levels of calcium, fasting insulin, HOMA-ER, HOMA-B, fasting glucose, and BMI. patients can be categorized according to their glucose metabolism profile. Indeed, HOMA-ER and HOMA-B can be dichotomized into two categories according to their percentiles. We used for the study as threshold for HOMA-ER the 50th percentile and the 75th percentile for HOMA-B. So patients can be categorized in the group low ER, high B. These are the patients who have the lowest fasting blood glucose level. In our study, it was of 0.8. Then they can be categorized in the group low ER, low B, high ER, high B, and high ER, low B. These patients in the group high ER, low B were the ones who had the highest fasting blood glucose level. And when we analyzed the evolution of insulin resistance according to these profiles, we found that for the group high ER, high B, there was a significant decrease of insulin resistance of minus 1.59. For the group low ER, low B, there was a slight increase of insulin resistance of 0.37. We did not find any significant changes for the other two groups. We analyzed the evolution of insulin resistance according to prediabetes. In the group ADA, that comprised of 75 patients, we find a significant decrease of insulin resistance of minus 0.69. In the WHO, which comprised of 27 patients, there was a greater significant decrease of insulin resistance of minus 2.02. In the ADA group that comprised of 75 patients, 19 patients normalized their fasting blood glucose. When analyzing these HOMA-ER changes after surgery according to preoperative glucose metabolism characteristic in a multivariate analysis, what remained significant was preoperative HOMA-ER superior to 2.5, preoperative HOMA-B, and prediabetes. Age, BMI, and pre-op calcium did not remain significant. We did not find any significant decrease of insulin resistance in all patients at 12 months. However, preoperative levels of insulin resistance, level of pancreatic beta cell secretion, and level of fasting blood glucose were three significant preoperative predictive criteria of improvement of insulin resistance after surgery. In the study, we showed that patients with a profile high ER, high B were the ones who had the greatest improvement of insulin resistance after surgery. We also showed that pre-diabetic patients improve their insulin resistance after surgery. 25% of our patients normalized their blood fasting glucose. We acknowledge that it may be easier to use the pre-diabetic definition than to classify patients according to their glucose metabolism profile. So to conclude, improvement of insulin resistance after surgery is determined by preoperative glucose metabolism. Pre-op glucose metabolism should be taken into account into future studies. Beta secretion may be an explanation to the discrepancies in the current studies. We think that prediabetes could be a criteria that could be added to international guidelines for surgery. Thank you for your attention. I'm looking forward for your questions.
Hi, Alan Superstein, Cleveland Clinic, no disclosures. This is a really provocative study because, once again, has the potential to expand the indications for parathyroidectomy. We know that calcium is a secretagogue for multiple pancreatic hormones. We use it, acute boluses of calcium in the Imamura test, and we know that, for example, in patients with MEN1, after parathyroidectomy, we often see hormone levels drop, often very dramatically. I'm just very interested if you could elucidate a little bit more on what you think the mechanism is of reducing the insulin resistance. I very much enjoyed your paper.
Thank you. Great question. I do not have the answer to this question. I do have some hypotheses, and we think it may be in connection to intracellular calcium, because we know that exosystole of insulin is mediated by intralevel calcium, so that may be a hypothesis, but I do not have the answer to this question right now.
Quantum from San Francisco. What a wonderful presentation. I was just thinking there and talking to our table mate there. The endocrine surgeons in this room are curing diabetes by doing bariatric surgery, by taking care of Cushing's patients, by taking care of pheochromocytoma patients, and all of these things improve insulin secretion, insulin resistance, etc. So I find this an absolutely fascinating paper. The question I have for you is similar to if you think about like pheochromocytoma. After you've cured the patient of pheochromocytoma, you have to watch out for the blood glucose.
Yeah.
Because those that are diabetic before your operation, their requirement for insulin dramatically drop. So the question I have for you is, why did you exclude the diabetic patients? Maybe you should look at them and see whether there's improvement in their diabetic treatment.
Yeah, very good question. We excluded diabetic patients because we wanted to minimize any biases, and since the diabetic patients are require medication, it may have caused biases. But effectively, we should do another study comparing like insulin resistance and insulin secretion in diabetic patients. Yeah, we should. We will.
Yeah, paper.
Okay. 1 minute we have for Dr. Nabnet. Go ahead.
And Barry Nabnet, Lexington, Kentucky. I agree with Dr. Sipperstein and do just fantastic study. I think Alan really raised the key issue, or the key point, is that calcium is the key to incretin secretion. And we know if you look at GLP-1, for example, I mean, all of these incretins are calcium mediated in their release. And when you do a gastric bypass or even a sleeve gastrectomy, you are greatly altering PYY36, GLP-1, and many of the hormones that impact hunger on the brain and the metabolism of glucose at the GI level. So I imagine there is some sort of mechanism that when you return a patient to euglycemic state, that you are altering the GLP-1 balance. I mean, look at Ozempic. That's like all the rage now. It's a GLP-1 agonist. So there's something at play that involves calcium, and that's the challenge to you and your team to continue to dig, because I think this is a really important area of research. Great job.
Thank you. Thank you so much.
Next, we have a prospective comparison of octreotide to vasopressors as first-line treatment of intraoperative carcinoid crisis, presented by Belinda McCulley.
Good morning, President Sturgeon, members and guests. We have no disclosures. Patients with carcinoid disease who require operative treatment are at risk for carcinoid crisis. This is characterized by a sudden onset of hemodynamic instability, which is typically profound hypotension. This occurs in approximately 25 to 30% of patients, and if sustained, can result in total circulatory collapse and death. Was there a mouse? So this is a video of a patient who is about to endure a carcinoid crisis. So if you look at the red tracing, that's the blood pressure tracing, and the numbers to the right are the systolic blood pressure, diastolic blood pressure, and the mean arterial pressure. And so as the video progresses, now you can see that we start to see this drop in blood pressure. It's very much unpredicted. It's a very scary situation. During the case, now we're at 56, 54, 52. It continues to drop more and more, again, creating a very dangerous situation. Historically, it's hypothesized that carcinoid crisis is attributed to a sudden and massive release of vasoactive hormones from the tumor. And accordingly, octreotide, which inhibits the release of these hormones, has been recommended in several guideline papers for the prevention and treatment of carcinoid crisis. However, several papers from our group, which has been presented to the association previously, actually contradict these findings, showing that octreotide is not effective in preventing crisis. This has been confirmed by other groups and also in meta-analyses. In a prospective study also presented to this association, we found that there is actually no hormone surge during crisis, which contradicts the historical hypothesis and also a justification for the use of octreotide. Therefore, crisis is a form of distributive shock for which the correct treatment is fluids and vasopressors and not octreotide. These data severely undermine any potential role for octreotide in preventing or for the prevention of treatment of crisis, and accordingly, our center stopped using octreotide in January of 2017 and switched to vasopressors as a first-line treatment. As a result of our research, guidelines have begun to change to stop using prophylactic octreotide. However, there are still recommendations for using it as a first-line treatment, but the data are scant and really based on 2 papers. The first is a paper by Coles et al., where this was based on a case study. And in this patient, you can see that there is this drop in blood pressure, likely that's attributed to a crisis. They give octreotide, and then you see this immediate restoration of blood pressure. The second is by Kinney et al., by which they anecdotally state that patients with carcinoid crisis rapidly respond to additional IV boluses of octreotide, but there were no data to support this statement. And in fact, the actual effectiveness of octreotide as a therapy has not been assessed in a large series. And therefore, we hypothesize that octreotide is not as effective as vasopressors for first-line treatment of intraoperative carcinoid crisis. To test this hypothesis, we utilized a prospective carcinoid anesthesia database, and this database included patients with carcinoid disease who had major abdominal operations and were performed by a single surgeon. This database is unique because we are also able to assess 2 unique cohorts of patients from 2 different eras. The first was prior to 2017, where patients were treated both perioperatively and therapeutically with octreotide. And then we also had our vasopressor group, which these are patients from 2017 and on, by which we stopped using octreotide and only used vasopressors as a first-line treatment. During crisis itself, patients in the octreotide group were given bolus doses of 500 micrograms of octreotide and vasopressors if needed. And in the vasopressor group, again, there was no octreotide treatment, and they went straight to vasopressors as a first-line treatment. And in both protocols, IV fluid resuscitation was also utilized. The definition of carcinoid crisis was the same between groups. This was defined as a sudden onset of hemodynamic instability, not attributed to other physiologic factors, and both the attending surgeon and the anesthesiologist had to agree there was no other plausible cause. When assessing our surgical data, we found that there were 150 cases in the octreotide group, and we had 195 cases in the vasopressor group. Crisis incidence was similar between groups. However, there were more complex operations in the vasopressor group. But despite this, the vasopressor group still had a lower median anesthesia time and length of stay. As shown in this box plot graph, where we have our medians, we have the interquartile range, and then our full range, you can see in the octreotide group that the median crisis duration was about 6 minutes. However, in the vasopressor group, this was reduced to 3 minutes, which was statistically significant, and showing that vasopressors alone reduced crisis duration by 50%. We also found that 27% of patients in the octreotide group had crises of longer than 10 minutes, by which 96% of patients needed pressors to resolve their crisis. In the vasopressor group, there were no patients who had a crisis longer than 10 minutes. In terms of aborted operations, there were 2% of patients who, in the octreotide group, who had aborted operations due to a medically refractory crisis, and again, no patients in the vasopressor group. So in summary, using prospectively collected data, we show that compared to octreotide, patients administered vasopressors as a first-line treatment had a 50% reduction in carcinoid crisis duration, no crises longer than 10 minutes, no aborted operations, shorter anesthesia time, and shorter length of stay. So now going back to the Coles paper, we have an alternative explanation for what may have happened here. Our data do not support this instantaneous rise in blood pressure following the octreotide treatment. What's been overlooked is that this patient was given fluids and vasopressors about 4 minutes prior to the restoration of blood pressure, which is a similar duration of response time that we found in our paper. So we propose that this patient was actually responding to the vasopressors, creating an illusion that this was attributed to octreotide. In conclusion, vasopressors and not octreotide should be used as a first-line therapy for crisis, and guidelines should be changed to reflect these findings. Thank you, and we welcome any questions.
Go ahead. I can't see. Yeah, I can't see her.
Mary Beth Hughes, Norfolk, Virginia, Eastern Virginia Medical School. Thank you for that paper. One of the questions I had, I know your group has shown that the somatostatin analogs that are long-acting has not prevented crisis. But did you look in these two groups to see if there was a differential? Because most of those complex cases in your vasopressin group would have come in on lanreotide or octreotide LAR. And so can you tell me the difference between the two groups and who was getting preoperative monthly LAR?
That is a great question. I'm not sure of those data prior to what their monthly treatments were prior to their surgery. We focused on the pre-infusion and then any treatment for crises. So at the time, I'm not aware of exactly what those differences look like between the two groups.
Yeah, I would just encourage you to go back and look at that because it's a big difference between who crisis is if they're on long-acting.
Absolutely, thank you.
So, greatly presented paper. How was the data collected by anesthesia? Prospective, retrospective, was computerized, handwritten, and were there any differences in the between the two study periods of how you did that? Because sometimes that could be subjective. Mm-hmm. And then second, how does octreotide work in terms of timing when you give it? You show that older graph. And is it still helpful in your patients in some way, shape, or form?
Mm-hmm. In terms of how the data were collected, I'm not aware of a difference between the two groups of how those data were collected. I know that they were assessed by anesthesia records, and then we use that to compile our database. In terms of the timing of octreotide, I would think that there would be some fairly quick responsiveness, since we did see that in the octreotide group, they did, on average, the crisis was resolved within a 6-minute time frame on median, but there was a range between that depending on how severe the crisis was. I'm sorry, may I have the second part?
How do you find usefulness to octreotide at all in the perioperative period with this new data you're presenting?
We don't, based on the data, we actually don't see a true usefulness for it. And so, in fact, it may be attributing to a longer response time in terms of using the octreotide first and then having to go to vasopressors. Instead, if you can go straight to vasopressors, that can help reduce the time that the crisis can be resolved.
And one more question. I think you said it was vasopressin you were using. You keep saying vasopressor. What's your preferred agent to start with, or does it depend on what you're doing?
Based on the protocol, it was vasopressors followed by phenylephrine and then beta-adrenergics after that.
Okay, thank you very much. Excellent.
Great, thank you.
The next paper is entitled Radiofrequency Ablation of Thyroid Nodules, a Prospective Multi-Institutional North American Experience, to be presented by Dr. Jonathan Russell and the multi-institutional group.
Good morning. Pleasure to be here with you today. I'm John Russell from Johns Hopkins University, presenting a multi-institutional study on our experience with radiofrequency ablation. These are our disclosures. Radiofrequency ablation has been discussed to some degree at this conference. We know that it is routinely being offered at some institutions to patients with benign symptomatic thyroid nodules. It's growing in popularity, and there are multiple national and international guidelines regarding the use of radiofrequency ablation, but relatively limited long-term or even short-term North American follow-up. Our objective was to describe the rollout of radiofrequency ablation at 3 academic hospitals in North America, Tulane University, Stanford University, and Johns Hopkins University. At Tulane, these procedures were performed by an endocrine surgeon, and at Stanford and Johns Hopkins by head and neck endocrine surgeons. All radiofrequency ablations were completed by fellowship-trained surgeons, primarily using the long-axis transismic moving shot technique. The data was prospectively collected and then retrospectively reviewed, including demographics and treatment characteristics, as well as follow-up. We used 2 different devices. We used the RF medical device. We also used the StarMed device as per institutional policy, including different sizes of active tips. All benign nodules that underwent radiofrequency ablation were included. This required, as per guidelines, it required 2 benign biopsies in almost all cases, unless a nodule was spongiform on preoperative sonogram, and in which case only a single benign fine needle aspiration was required. We then completed evaluation and analysis of our data. We excluded any patient with indeterminate or malignant cytology. It should be noted that there was some discrepancy between the authors and institution as to how a benign nodule was defined. At one of the institutions, an indeterminate nodule could be considered benign if a subsequent biopsy considered it benign, but that was not the standard at the other institutions. Also, patients who had a history of previous treatment with either radioactive iodine or radiofrequency ablation or ethanol ablation were also excluded. And then any patient who did not have at least 3 months of follow-up was also excluded. We'll need some definitions first. We used the American Thyroid Association definition to define the volume of the nodules, and that is length times width times height times 0.5. And so for an idea of what that means, a 3 by 2 by 2 centimeter nodule would be approximately a 6 cc volume nodule. And then the volume reduction rate, which is how we define success, was the initial volume minus the post-ablation volume divided by the initial volume times 100. For the purpose of this series, we considered success a volume reduction rate of at least 50%, and regrowth, which we defined differently than how it is often defined, as any nodule regrowth that exceeded the initial size, the pre-ablation size of the nodule. These are our baseline characteristics. You'll see the blue arrow is the Hopkins data, the cardinal red is Stanford, and then the Tulane is green. And just to provide a brief synopsis, we had 620 patients. The average age was 58 years old. Most patients were female, a majority were white, with a BMI of approximately 30. Again, moving on, most of these patients were euthyroid. The average nodule size was about 6 cc's. Approximately 40% of these nodules were more than 10 cc's, 23% were more than 20 cc's, and most of these nodules were solid. You'll note that there were some differences between the groups. The Hopkins and the Stanford groups tended to treat larger nodules with an average size of approximately 16 and 17 cc's respectively, which approximates a 4 by 4 by 4 centimeter nodule. Whereas the Tulane group was treating smaller nodules with a median volume of 2.8 cc's. They also used a different device, and they were more likely to use the lateral to medial approach in their treatment. The results moving forward, at 3 months, 53% of the patients had achieved what we considered success, a volume reduction rate of more than 50%. At 6 months, that had increased to 71%. At 12 months, that number had increased to 78%. And you can see across all institutions, the results were fairly similar despite the differences in patient selection, etc. This is a graph of our results demonstrating the improved but seeming to plateau volume reduction rate over time. This is an example. We had showed you going back a couple of slides, if it'll let me go back. This is an example of a nodule on the right that approximates what the Hopkins and Stanford groups were doing with the 10 cc nodule. And this is the post-treatment example of what that looked like with a 77% volume reduction and a maximum dimension of 2.4 centimeters. We then reviewed which factors were associated with success, and what we found was that most factors did not seem to stand up on multivariate analysis. However, having a larger nodule on pre-ablation ultrasound was associated with a lower likelihood of achieving a volume reduction rate of at least 50%. On follow-up, what we found was that approximately 7% had nodule regrowth, 90% of whom did not achieve initial success during an immediate follow-up. If you had initial success, it was highly unlikely that you would go on to demonstrate nodule regrowth within the follow-up period that we had. We also found that men were more likely to demonstrate regrowth than women. Complications, 2.3% of patients had voice changes. All of those resolved within 6 months. The vast majority of those had resolved immediately, and there was actually no changes on flexible fiber optic laryngoscopy at the conclusion of the treatment. A small percentage of patients had vasovagal episodes or were lightheaded, and there was nodule rupture in three patients, or 0.5%. So our conclusions were that radiofrequency ablation can be applied at different institutions with variable implementation strategies, and there is a high likelihood of success. Approximately 80% of patients will achieve a volume reduction rate of 50% within the first year after treatment. Complications are rare and temporary, and radiofrequency ablation should be considered as a first-line therapy for symptomatic benign thyroid nodules. Now, lots of limitations with our study. It's a retrospective study, of course. Inclusion criteria varied widely between the institutions. The majority of the nodules treated were relatively small. There's limited data regarding the efficacy of a second treatment for patients who required it, and we had relatively short follow-up. Nevertheless, we do believe that this is a procedure that could be considered. Thank you.
This paper is now open for discussion. Dr. Du?
Quan Du from San Francisco. No disclosure, including that I don't do this. We actually thought about doing it, but John, what a wonderful presentation. I'm so glad that you brought data here. My question for you is actually related to the definition of success, because you're doing this for what is a benign nodule. So the success rate is really not the volume itself as much as whatever you're doing it for. Somebody does not like what it looks like in the mirror. Somebody has swallowing issues and all that. Do you have any data on the clinical success rate, not just the volume rate? Great presentation.
Thanks, Juan. You're right, and that's really the thing, right? It doesn't matter if the nodule is 2 centimeters or 20 centimeters, it's how much it bothers the patient if it's a benign nodule. We do not have that data in any meaningful way to present. There's a large body of international evidence that suggests that it does improve symptoms and cosmesis, but we don't have that here.
Alan?
Alan Silverstein, Cleveland. Enjoyed the presentation and very impressive multi-institutional collaboration. Being an old-fashioned RECIST criteria person, I wonder why you use a volume as an outcome metric as opposed to what is really accepted in surgical oncology is using RECIST criteria, which is the greatest linear dimension. In my mind, there may be a little obfuscation because a 4-centimeter lesion, 50% volume reduction goes to 3.4, and a 3-centimeter lesion goes to 2.6. You know, and so when you hear that, or sorry, 2.4. So when you hear that, I mean, my mind is less impressed. So question number one, why did the group choose to use a non-standard outcome metric? And number two, are you planning to follow these patients? Because I'd be very interested in your presentation in a year or two. Thank you.
Thanks. So with regards to radiofrequency ablation and the criteria that we used for follow-up and definition of success, that is what is kind of internationally accepted as the method. I think symptomatically, going back to Quan's point earlier, symptomatically the volume seems to matter perhaps a little bit more than the linear dimension. And so hard to say for sure with regards to that. The second point, certainly we plan on following all of these patients, and that's really going to be what matters, because if by 3 years they're all back to where they started, then we've been wasting our time.
Yeah, hi, Matt Nays, Boston. Do you have experience with operating on these patients that failed? I've operated on one patient, and I was concerned about scarring, and that it would be a challenging operation. And it was actually quite easy, but that's just an N of 1.
That is our experience as well. There is some scar tissue, but it's all superficial along the strap muscles and does not seem to affect anything in a meaningful way. So different, very different from ethanol ablation.
Jonathan.
Sorry, one. Oh.
Yeah.
Full disclosure, I'm asking this question so I can transcribe it into the journal, because...
Oh, great. Thanks.
Full disclosure,
For the
right.
warning.
So quick question. And I'm Kapil Patel from New York. Did you see an increase in your volume reduction over time corresponding to the experience from early RFA ablations that you did during your first couple of months when you started doing it, and over time, and how did that correlate to the total amount of energy you were delivering to these nodules? That's question one. And then the philosophical question that we talk about every day is, how do you, once the CPT codes for this procedure are available, how should we regulate using this procedure as a society, as a group of individuals that do this on a regular basis? From people just now ablating 1 centimeter and 2 centimeter nodules that clearly need nothing done. Just because you can easily see the scenario, well, oh, you have a 2 centimeter nodule, let's ablate it now before it becomes 4 centimeters, right? And that's going to be a really difficult problem to solve. So just your thoughts on that. Thank you.
Well, since I'm on the record, I'm going to be a little more cautious as I answer everything. The first question, kind of, yes, anecdotally, we did see that the more experience we had, the better our results became. That actually didn't stand up on a review of our data, meaning that with regards to the joules that we were putting into the nodules, half of our group was not able to record that data. The other half had it. But even on the patients that we were recording it, what we all expect, the amount of energy that you put into a nodule is related to the volume reduction, did not stand up in our data. It was close, but it was not statistically significant. And so I will tell you anecdotally, I'm definitely sure that I've gotten better over time. I just can't prove it based on the data that we have. Now the second question, philosophically, should we be treating 2 centimeter thyroid nodules that are benign? Certainly if they're symptomatic, I think we can all agree that it's probably a safer option than surgery and probably has some advantages for patients. Asymptomatic patients is where it starts to get sticky. Once there's a code that's available, if it's growing, we do know, again, we demonstrated that smaller nodules have better results, and you can even make 2 centimeter nodules completely disappear on sonogram and fairly routinely. And so the question is, are we doing a service to patients or not? Because if 80% of Americans over the age of 50 have a thyroid nodule, and we start ablating every benign thyroid nodule, we're probably not doing a service to most patients in America. Somewhere in between there is the truth, but it's going to take societies and guidelines to really define what that is.
Thank you very much. The next paper is entitled Normocalcemic Hyperparathyroidism, Intervention to Differentiate Primary from Secondary Disease, to be presented by Dr. Ball and the group at Pittsburgh.
Hello. Well, good morning, everyone. Just like she said, I'm Catherine Ball. I'm the fellow at University of Pittsburgh. Thank you for the privilege of the podium, and today I'll be presenting our study entitled Normocalcemic Hyperparathyroidism, Intervention to Differentiate Primary from Secondary Disease. And we have nothing to disclose. So as we all know, primary hyperparathyroidism results from autonomous parathyroid hormone production despite normal or elevated serum calcium. Typically, it is associated with hypercalcemia. However, there's a unique subset of patients identified that are repeatedly normocalcemic. Now, studies have shown that 5 to 17% of hyperparathyroid patients are normocalcemic. And this represents a diagnostic and treatment dilemma, as the etiology is divided into 2 general schools of thought. First, that it represents a secondary elevation of PTH due to, say, renal failure, malabsorption, medications, vitamin D, or calcium deficiency. And the other school of thought or hypothesis is that it represents the early phase of a biphasic disease process in primary hyperparathyroidism. The early phase is usually asymptomatic, but can be associated with kidney stones or bone demineralization. And the late phase is associated with hypercalcemia and classic symptoms. So as you can see, this becomes very problematic as the treatments are very different. So we sought to determine if implementation of a preoperative oral calcium challenge helped to differentiate secondary from primary PTH elevation and to be used to reduce unnecessary parathyroid exploration. So first, I wanted to review our typical management strategy. We reviewed all data from patients who were referred for consideration of parathyroid exploration from January 2021 to June 2022 for one surgeon, Patients were included if they were repeatedly normal calcemic, so calcium less than 10, and then we used this typical management strategy. Patients were reviewed for causes of secondary hyperparathyroidism, including medications. Vitamin D levels were checked, and if low, burst therapy of 50,000 units weekly for 8 weeks was given. A 24-hour urine calcium was checked, and if high, then we would consider a renal leak and an HCTZ challenge was given. Otherwise, we would proceed with a calcium challenge, which included 1 to 4.5 grams of supplemental elemental calcium. And then we had patients get repeat labs at 2 months. So endpoints we were looking for was classic hypercalcemic hyperparathyroidism, normalization of PTH, and stable disease. So during that 18-month period, 314 patients were referred to the one surgeon. 9% of those patients were normal calcemic, and out of those 29 patients, 27 of them, or 93%, had follow-up labs after being initiated on calcium supplementation. And so as you can see, with calcium supplementation, the mean PTH decreased to 80 from 109, while the calcium level did not significantly change. And the vitamin D level increased from 42 to 48. And so what we found was that of those 27 patients, 7 patients, or 26%, had stable or unchanged labs. But 55% of patients, so 15 patients, actually had normalization of their PTH levels. And 19% of patients went on to develop classic biochemical evidence of primary hyperparathyroidism, so i.e. hypercalcemia. And when you divide the patients into the 3 subgroups, you find some interesting results. In the patients who developed classic primary hyperparathyroidism after calcium supplementation, the PTH and vitamin D levels did not change significantly, but the calcium level increased from 9.7 to 10.3. And in the patients that had normalization of their PTH, we saw that the mean PTH decreased from 104 to 48, while the calcium level remained equivalent. And in the patients that had stable disease, we did not see any significant changes in the PTH, vitamin D, or serum calcium. We then manage each of these patients according to their response. If they normalize, then they're referred back to their primary care doctor or their endocrinologist for continued surveillance. If they have stable lab values, then we continue to surveil for development of classic hypercalcemic hyperparathyroidism. And if they developed classic primary hyperparathyroidism after calcium challenge, then they're scheduled for surgery. And to date, 3 of 5 patients have undergone parathyroid exploration, with surgery occurring 4.5 to 6 months after their follow-up labs. And in those that underwent surgery, 2 of the 3 underwent bilateral explorations, and none of them have had postoperative complications. So we have to consider the limitations of our study. First, this was a prospective management algorithm, but of a small number of patients. We did not check for compliance with the regimen, and additionally, total calcium, which includes dietary and supplements, was not assessed. Our study did occur in a geographic region with a high prevalence of vitamin D deficiency and potentially other nutritional deficiencies, so it may not be applicable to a generalized population. And there was also limited follow-up. And so we recognize that it's a small number, but with significant and very interesting findings that we wanted to present. And so the main takeaway points are that calcium supplementation resulted in normalization of PTH in 55% of patients, which avoided unnecessary surgery. Classic primary hyperparathyroidism was diagnosed in 20%, so a fifth of patients, allowing for prompt scheduling of surgery. And all in all, we were able to use a safe, easily tolerated, and inexpensive intervention to help distinguish patients who needed surgery. So thank you for your attention. I'll take any questions that you have.
Paper is open for discussion. I think that's Dr. Schneider, but I'm not sure.
Hi, Dave Schneider, Madison, Wisconsin, no conflicts. Catherine, great talk. I think you guys have kind of formalized what a lot of people in the audience kind of have been doing, but just, created a protocol, and so congratulations on your work. My question is a little bit about the timing. So we know that patients with secondary can still have an elevated PTH for 6 months or longer after correction of the secondary cause. And so I guess I'm wondering a little bit about how long you guys sort of monitor these patients. And in the patients that have quote unquote normal labs, with, let's say they have, like you showed, I think the calcium was 9.7 and the PTH is let's say it's 70 or something, I'm still a little bit kind of suspicious of that relationship, right? So how long do you monitor these patients is the question. Thanks.
So, great question. We repeated labs at 2 months after supplementation. We then referred them back to their PCP or endocrinologist, so we have not, that is one of the limitations of our study, is we have not continued our own follow-up of those patients. So far to date, none of them have been referred back to us for development of hypercalcemia afterwards, but it is definitely a limitation and something that we should look at.
Dr. Wang?
Hi, Tracy Wang, Milwaukee, Wisconsin. Thanks for a nice presentation. I wonder if you can comment on if you have data on ionized calcium levels, because we routinely get them, and as you know, true normal calcemia, they will not have normal ionized calcium levels. And in relation to that, with the normalization of PTH, how low are you willing to say is non-suppressed, or high, I guess, would you say is non-suppressed, particularly in the setting if you also are looking at their ionized calcium levels? Some of these patients may still actually have primary hyperpara.
So good question as well. We do not routinely get ionized calcium, so that data was very limited in these patients. That is something to look at, but we routinely do not get ionized calciums on these patients. And then, as you were saying, like what our level is for PTH, we essentially went with normalization. That is a limitation. We did not look at if it was suppressed to less than 25, but we looked at it if it was if it's normalized to less than 65.
All right, thank you.
Dr. Javid?
Mahsa Javid, University of Louisville, no conflicts. Did you have any data on the bone density of these patients and if the different categories of response was related to that? And secondly, of the patients who did have surgery, did the pathology confirm multi-gland hyperplasia, and what was their post-operative course like?
Mm-hmm. So actually, a third of the patients did have a diagnosis of osteoporosis beforehand. We don't have the data afterwards to see if there's any improvement. But, and then of the 3 patients that underwent surgery, 2 were found to have multiglandular disease on pathology, and that's why they underwent bilateral exploration.
And they had no problems with post-operative hypocalcemia?
Correct, no.
So you mentioned that you check urine in your algorithm. I commend you for writing down what I think a lot of us already do in the clinic. So can you tell me when that was useful to you? Did you see any of those patients that you had a urine leak on, or it pushed you to do something different? And my second question is, I think that this disease, a comment and a question, I think that the more you treat the disease, the more you don't know what you're treating, because we just keep learning. So the follow-up is a big key here. And what was your median? I think you wrote it down, but who is going to follow these patients?
Mm-hmm. So in terms of the renal leak, we actually didn't have any patients that had a renal leak, so we did not have to give an HTTZ challenge to any patient. In terms of follow-up, our follow-up was variable. We did ask them to get labs at 2 months. However, we all know that patients are somewhat non-compliant, and so our range was anywhere from the most extreme was to 18 months, and that was, again, just they refused to follow up initially. And so we do rely on them to go back to their primary care doctor and continue getting their follow-up labs if they don't come back to us.
Thank you very much.